Let's get the place right. Well, good afternoon. We're with Stine Emil Volstedt, who's speaking to us from Seattle. Good afternoon to you from London. You were the lead author on chapter 15. And in a sense, it's the last chapter in the CMO's report. It is interesting because it's the one that really takes us to have a look at what health is going to be like in the UK by 2040, which is really the whole purpose of the CMO's report. You've adopted a really interesting scenario approach. Perhaps you could start by telling us a bit more about that.
Yeah, what we have been doing is, in fact, within the global burden of disease approach, we are forecasting global burden of disease mortality results into the future using, as you say, a scenario approach. And what we are doing is we are first projecting the main drivers of health, which are the major risk factors like smoking, BMI, air pollution. We are also accounting for some vaccines and socio-demographic indicators. And our sort of reference scenario is the most plausible future for mortality that we see, and that's based on letting the drivers of health follow recent trends into the future. We also account for changes in population and population age structure. And then we have two alternative scenarios, which is one which is we think of as plausibly better than the most plausible one. And we obtain that by setting the drivers of health based on the distribution of rates of change of the risk factors and other drivers observed across 195 countries from 1990 to 2016. And then the better scenario is based on observed rate of change in all the drivers of health across countries and recent years. And it's constructed by setting all risk factors and other drivers to the 85th percentile of that distribution. And from that we get mortality rates that are lower than in the reference forecast. And conversely, we construct a plausibly worse scenario by setting the rates of change of all drivers of health to the 15th percentile of that distribution. And then we see, and then we apply that to the model, and the resulting mortality is higher and worse than in the reference forecast.
So this is an enormously complex piece of work, and a lot of research has gone in it. What interests me is how ischemic heart disease sticks stubbornly at the top of the list.
Yeah, that's correct. It sticks stubbornly at the top of the ranking list.
Yes.
For the leading causes of years of life lost in 2040.
Yes.
But that does not mean that all is gloom, because it's actually decreasing quite a lot. But because it's such a major cause of death, and especially of years of life lost, which actually are deaths weighted by when in life death occurs. So a weight early in life will weigh much more than a death late in life.
I see why that gets the preeminence it does, because there is a lot of movement under that. Alzheimer's, for example, comes up to from 4 or 5 to number 2. And one can imagine a time where that will be the leading cause of death.
And Alzheimer's is actually going up in numbers of years of life lost, whereas actually ischemic heart disease is going down quite a lot.
So they're likely to be
as number 1. Yes.
Yes, that's interesting. Yeah. The scenario approach is interesting, isn't it? Rather than a sort of straight forecast. Why did you approach it from that point of view?
One of the key features of our novel way of forecasting mortality is that we actually forecast the drivers of mortality, say like smoking, BMI, high blood pressure. And actually we can, in principle, we can construct any future scenario by setting. We could also, for example, we could say if everyone stops smoking, what will happen then in the future? If blood pressure go down, and we could specify how much we want it to go down, and then we could assess how that would affect future mortality. So we have a machinery that we actually can adjust the causes of or the risk factors that are causing changes in mortality, and we can sort of modify them and picture what will happen to mortality in the future.
It's a very sensitive approach, isn't it? I also note in your chapter that you don't factor in climate change. Is there a reason for that?
We would like to factor in climate change, but that's a big challenge that we are working on, and hopefully we will be able to do that at some point in the future. And actually, within the Global Burden of Disease project at the moment, we have started with addressing temperature as a risk factor for health.
You've had a go at predicting the future, and of course the one thing we all know is the future comes a lot quicker than you think, and it usually comes wearing a different pair of trousers. So where do you how confident are you? What's the confidence on the forecasting, do you think?
No, I think the way I look at this is that we do not pretend to see into the future. What we are doing, and I think that's it's very useful for planners and policymakers. We are trying to project the future that we will experience if the current trends in drivers of health continue as they have in the recent past. And they very well may not do so.
Yes.
Then we will have a different future. But that's what we say. That's the most plausible one. That's the reference.
Yeah.
And then we also set these drivers to a plausibly worse and plausibly better settings, and see, and we call that between the reference and no, between the better and worse scenarios, we call that a scope for change. That's sort of what we think is something you could be able to change with good policies, or go to the worst with lack of policies.
Yes, it's a very elegant approach, if I may say so, and it fits very well. I mean, this is not exactly in your purview as far as your chapter is concerned, but of course then once we're left with the problems, the question is, well, what do we do about the problems? And in a sense, sort of medical science just follows the problems and clears up our ills and ailments. The real issue, of course, is the political will that there is to interfere in some of these very big issues, smoking, diet and exercise and so on. You know, one imagines that governments have done clean water, adult literacy and childhood immunization, and now they've, you know, do they interfere or involve themselves in our lives anymore, which does then have the opportunity to change a scenario.
Yeah, and I think this is a good point, and of course it's one that we don't address. We don't in the chapter, but I think it's an important lesson to learn from our projections of what we see as the most plausible future, is that the main drivers will stay the same. The main risk factors in 2040 are the same as they were in 2016, and that is smoking, high blood pressure, and overweight and obesity. Yeah. So we have to continue to address them and never let those go. We have not solved those issues.
It's really interesting to talk to you, and thank you so much for giving us your time, and congratulations on a most interesting chapter in this fantastic report. Thank you very much. Thank you.
Okay. Thank you very much, and thanks for the opportunity to present.